Just be happy with who you are. Just be happy with who you are. Just be happy with who you are.
Hi, and now we're going to look at the chapter Gender Dysphoria, Paraphilic Disorders, and Sexual Dysfunctions. Now, attitudes towards sexual activities are incredibly diverse. So what is normal is clearly influenced by sociocultural factors. Sexual behavior may be labeled as abnormal if it deviates from the norms of one's society. It may also be labeled as abnormal if it's self-defeating, harms others, causes personal distress, or interferes with one's ability to function. Let's consider Sally and Dave. Sally and Dave decided to seek therapy after only 8 months of marriage. Both were extremely dissatisfied with their sex life. Dave complained that Sally never initiated sex and found excuses to avoid it and appeared to be faking orgasm during intercourse. Sally complained that Dave's lovemaking was often brief, perfunctory, and without affection. During the therapy sessions, it appeared clear that Sally had never had a strong interest in sex and seldom became aroused during intercourse. Although Dave never had difficulty with maintaining erection, sex with Sally had become progressively distressing, and he often had difficulty getting hard enough for intercourse. Now, the case of Sally and Dave illustrates psychological and physiological complexities associated with one of 3 groups of disorders that we're going to be reviewing in this chapter. Sexual dysfunction, which involves problems in the normal sexual response cycle. The other 2 disorders, gender dysphoria, distresses resulting from the incongruence between a person's gender identity and the assigned gender from birth. And then the third part is the paraphilic disorders. These are problematic sexual interests, fantasies, and behaviors. Now we're going to begin with a review about what constitutes normal sexual behavior and conclude this chapter with a review of sexual dysfunction. For this chapter, we're going to look at the descriptions of the disorder, the theoretical perspectives, and the treatment for each group, one group at a time. This follows the chapter. However, it makes for a longer video rather than the 3 separate ones that I've done in the past. So let's get started with gender dysphoria. In gender dysphoria, an individual experiences significant personal distress or impaired functioning as a result of discrepancy between his or her anatomic sex, biology, and gender identity, which is influenced strongly by sociocultural factors. Transgender identity is a type of gender identity that a person with a psychological sense of being one gender and possessing the sexual organs of another. Now, not all people with transgender identity have gender dysphagia disorder, as many are not distressed about their identity and have access to the supports that they need. Gender dysphoria pertains to people who find their anatomic gender to be a source of persistent and intense distress. Now, in all of these conditions that we're going to be reviewing in this chapter, that's going to come up a lot. A source of persistent and intense distress. It doesn't make the person feel good that some of these things are happening. Now, people with the disorder may seek to change their sex organs to resemble those of the opposite gender. And many undergo reassignment surgery to accomplish this purpose. It's important to understand that sex and gender are not interchangeable. Sex relates to our biology and gender is socially constructed. Part of the issue with gender is how we tend to treat, at least in our culture, as a polar opposites, men and women. However, gender is more on a continuum. Men being at one end and women being at the other, men at one end and sort of beginning at the other, and many variables in between. In North America, In North American culture, we generally see two genders. However, in other cultures, the social constructs sometimes have more. 3 genders, 4 genders, even 5 different socially accepted genders. Really reminds us of how connected gender is to culture and society. So some of the theoretical perspectives of this. The psychodynamic theorists point to extremely close mother-son relationships, parents with empty relationships, and fathers who were absent or detached, or girls with weak and ineffective mothers and strong masculine fathers may develop stronger little men identities and behavior. Now, psychodynamic theory often looks towards the past and looks towards some of Freud's psychosexual stages, and it hasn't had the kind of support empirically for it to hold as much. Now, the point that they're trying to make is that some of the childhood experiences, the long-held belief that the childhood experiences can have this sort of impact on one's life later in life, that some of the goods and the bads that occur in childhood can have impacts on our adult life. Learning theorists, they have a similar focus where socialization patterns have a big effect. They point to the father's absence in cases of boys and the unavailability of a strong male role model. However, not the sole responsible features in the development of gender dysphoria. To better understand, you need to read the story about Bruce from Winnipeg. Now, that's in your textbook, and it would give some indications that surgery isn't just the simple solution for some of this issue. This is far deeper than just, physical body doesn't appear to be right. There's more than a socialization or a parenting style to the development of gender dysphoria, and Bruce's example is a good one. You need to consider the biological predisposition, considering the gendered brain and the role of sex hormones. Prenatal hormone imbalance may also be involved. Perhaps the brain is masculinized or feminized by sex hormones during certain stages of prenatal development. Treatment for gender dysphoria, well, the recommended treatments for gender dysphoria include hormone therapy, real life experience, that is, living as the identified gender for, I think it's a minimum of 2 years, sex reassignment surgery, and psychotherapy have been the sort of predominant ways to help support people with gender dysphoria. Not every person with gender dysphoria seeks gender reassignment. Some of the more known people who have include Chastity Bono. She's the daughter of Sonny Bono and Cher. You see the picture of Chaz Bono. That was in 2011. Bono has gender identity disorder and has undergone hormone and surgical procedures to transition from female to male. Jenna Telkakova, she was in the Miss Universe contest in 2012, and she finished in the top 12 out of 62. And of course, Caitlyn Bruce Jenner. These individuals are more famous, and therefore, there's certainly way more people than just these famous few, and not so famous who pursue gender reassignment. So paraphilic disorders. Now, we're going to sort of review the types of paraphilic disorders and what they are, and then we'll go into some of the treatments. Now, paraphilic disorders are types of sexual disorders in which a person experiences recurrent sexual urges and sexually aroused fantasies involving non-human objects, such as articles of clothing. The sort of inappropriate or non-consenting partners, for example, in children, or situations producing humiliation or pain to oneself or to a partner. Now, persons has either acted on such urges or is strongly distressed by them. Now, that's important to note. Not everybody who has a paraphilic interest feels happy about that interest. Sometimes it costs them a great deal of distress. So the types of paraphilic disorders discussed in your text include exhibitionist disorder, fetishistic disorder, transvestic disorder, voyeuristic disorder, frotteuristic disorder, pedophilic disorder, and sexual masochism disorder, hypoxophilia, sexual sadism disorder, and sadomasochism. Now, some people diagnosed with paraphilias can function sexually without the paraphilic object, and some cannot. Some people with paraphilic disorders are men, a good number, but women may have been overlooked. A lot of the research that has been done historically in studies have been predominantly on men with some indications about women, but it seems that a lot of the statistics that have generated over the years don't necessarily look at women as strongly as it does men. So what we're going to do is we're going to review each of these types. Exhibitionism. Now, this is the reoccurrent, powerful urge to expose one's genitalia to unsuspecting strangers. Now, they're not interested in contact. Most just in the the participant in the act and the response. They want the surprise look, the shock, or the sexually aroused victim. They're not interested in the contact. And again, it's reoccurrent and powerful for them. Fetishistic disorder. This is the reoccurrent and powerful sexual urges and fantasies involving inanimate objects, clothing, shoes, a body part, feet, nose, or situation involving sight, smell, or feel. Transvestic disorder is the reoccurrent and powerful urge and fantasy to cross-dress for the purposes of sexual arousal. Now, this is not the same as gender dysphoria, as men are typically heterosexual and do not consider themselves women. Voyeuristic disorder. These are urges and fantasies involving the act of watching unsuspecting people while they're getting naked or are naked or engaging in some sexual activity. The person either acts on these urges or is very distressed about having the urges and fantasies even in the first place. Frotteuristic disorder. These are urges and fantasies involved in rubbing against or touching a non-consenting person. Again, the person either acts on these urges or is very distressed about even having the urges and fantasies. And that's, again, with these disorders, it's important that not everybody is excited and pleased about having the disorder. These urges, maybe a person just can't manage and acts on them, but a large number of people are quite distressed about having the urges and the fantasies and don't act on them. But look at the impact it might have on the rest of their day and their life if these urges emerge and they continue to be distressed. Now, one, of course, that in sociology, we look at this as being in the taboo area, but it's very significant. The pedophilic disorder, the reoccurrent and powerful urges and fantasies involving sexual activity with prepubescent children. Now, this particularly damaging disorder can have long-lasting consequences to the survivors of the sexual abuse. Although some paraphilias are essentially harmless, such as a fetish type of disorder. Others, such as pedophilia and sexual sadism, often harm non-consenting victims. The development of persistent sexual offending against children sees two pathways. One is the antisociality, and the second is being sexually attracted to the prepubescent children. Now, the presence of both indicate a very high likelihood that the person will offend against children. Now, sexual masochism disorder. These are sexual urges and fantasies involving receiving humiliation or pain, either acted on or the person is distressed about having these urges and fantasies. Now, this can include dangerous forms of masochism and hypoxophilia. This is the autoerotic asphyxiation, arousal through the restriction or deprived of oxygen. It's very risky, and yet some people feel that compelled, that it's that much of an urge, that they act on it. Sexual sadism disorder. These are sexual urges and fantasies involving the inflicting of humiliation and pain on a sexual partner, either acted on or is distressed about these urges and fantasies. Sadomasochism, the sexual activity between partners involving gaining gratification by inflicting and receiving pain or humiliation. Now, there are other paraphilic disorders, many others, and many varying others. We won't go into them all, but the theoretical perspectives to sort of get a handle on where these may arise. The psychodynamic theorists see many paraphilic disorders as defenses against leftover castration anxiety from the Oedipal period. And this is, again, a very strong Freud perspective. These form a psychodynamic therapy are speculative, as there's really not any direct evidence for this. The part about the psychodynamic element that's important is looking back at one's history to see where there could be associations and links being made. The learning theorists explain paraphilic disorders in terms of conditioning and observational learning. Some objects or activity becomes inadvertently associated with sexual arousal. Paraphilic disorder may involve multiple biological, psychological, and sociocultural factors. Now, as far as treatment is concerned of paraphilic disorders, therapists of various theoretical persuasions have attempted to treat clients with paraphilic disorders. Psychoanalysts, they, for example, attempt to bring childhood sexual conflict, typically of the Oedipal nature, into awareness so they can be resolved in the light of the individual's adult personality. Behavior therapists have used aversive conditioning, for example, electric shock, to induce negative emotion and reactions to paraphilic stimuli or fantasies. Now, selective serotonin reuptake inhibitors, the SSRIs, are used in treating exhibitionism, voyeurism, and fetishism. Researchers think that there may be a relationship between fetishes and OCD. It's not been concluded, it's just something that's starting to be investigated a little further. Efforts to treat paraphilia are compromised by the fact that most people with these disorders don't wish to change. It could be that for some people the distress is in itself exciting. For others, they're not offended and they're not affected negatively by these urges, and maybe have found partners by which it becomes acceptable within that partnership. Now, I'm just going to touch on this. I find that sometimes some topics are more difficult to discuss in an online environment when we're not face-to-face to be able to talk things out, but sexual assault is one of those topics. Sexual assault is a violent crime, not a sexual disorder, and it's an important distinction to make, because sometimes misunderstand that in order to behave in a sexual assaultive manner, there must be some sort of disorder at play. A sexual disorder, not so much. The desire to dominate women or express hatred toward them may be more prominent motives for rape than sexual desire. A sociocultural perspective suggests that cultural attitudes such as stereotype of male aggressiveness and social dominance underlie a propensity to rape. Rape survivors have often suffered a range of immediate and long-term effects. So, as far as for sexual assault, we're not going to cover this topic. It's not a psychological disorder, and it's not in the DSM-5. This is not meant to diminish the seriousness of sexual assault. Now, we'll start looking at the third group, and this is sexual dysfunction. Now, sexual dysfunction involves problems with sexual interest, arousal, or response, and can be grouped into the following categories. 1. Disorders involving problems with sexual interest and arousal. 2. Disorders involving problems with orgasmic response. And 3. Problems involving pain during sexual intercourse or penetration, and this is particularly, of course, true for women. For a diagnosis to be made, a clinician needs to determine that the problem is not related to the use of drugs or medication. other medical conditions, severe relationship distress, or serious stressors, and it's causing personal distress that have lasted at least 6 months. So this isn't about the occasional inability. This is about ongoing and persistent. Disorders of sexual interest and arousal. There are 2 separate disorders related to men and women. Male hypoactive sexual desire disorder and female sexual interest/arousal disorder. And as you may have thought, what is normal level of desire? Much investigation needs to go into a diagnosis, as there are many variables to consider. Male erectile disorder is related to attaining or maintaining an erection. This does not include the occasional difficulty, but the persistent and reoccurring episodes. Orgasm disorder includes 3 types of disorders: female orgasmic disorder, an inability for a woman to achieve an orgasm, and for men, premature ejaculation or delayed ejaculation, which is either the absence of orgasm or persistent recurrent delay of reaching orgasm. The genitopelvic pain penetration disorder is diagnosed by persistent or recurrent pain experienced during vaginal intercourse or penetration attempts, with 4 primary symptoms. Some forms of genitopelvic pain disorder involve vaginismus. Now, the theoretical perspectives to help us get a handle on some of this: sexual dysfunctions, like most psychological disorders, reflect a complex interplay of biology, psychology, and other factors. Sexual dysfunctions can stem from biological factors such as disease or the effects from alcohol and other drugs. Diabetes is the most common organic cause for erectile dysfunction. Testosterone has a huge role in sexual interest and functioning in both men and women. Biological issues are the major cause of sexual dysfunction. Learning, well, it looks at the role of conditioned anxiety. Anxiety being linked to sexual activity, thus learning that sex and sexual situations are anxiety producing. They are also looking at the sexual fulfillment through our trial and error of sexual partners and messages that we may have learned from these experiences. Cognitive theorists, well, they're irrationality attitudes. They look at the irrationality of our attitudes and beliefs that are considered here for sexual dysfunction. Faulty thinking, that's always about the cognitive. Catastrophizing, globalizing, fear of failure, and performance anxiety. The sociocultural, well, they include factors such as sexually restrictive cultural learning. Where we're from have different views about sexuality. Sex used to be thought as the male activity. For women, it's been more of a duty. Now, this would not expose women to the self-awareness sexuality about the functions of their bodies. So what can we learn from tradition? What our roles of men and women are according to our culture. Culture will often dictate how we're supposed to behave or perform sexually. We get this either from the media, from the excessive amount of porn access that we might have, and all can have an effect on what we think we're supposed to behave like and whether or not we perform according to those reference groups, if you will. Now, treatment for sexual dysfunctions. Sex therapy focuses on the directly modifying problematic sexual behavior by enhancing self-efficacy expectations, teaching sexual competencies, improving sexual communication, and reducing performance anxiety. Now, this work in the area of sex therapy was pioneered by Masters and Johnsons in the 1960s. Disorders of sexual interest or arousal. Therapists try to use sexual fantasy and self-stimulation to rekindle the sexual appetite. In some cases, testosterone replacement therapy is used where that hormone is deficient. Disorders of orgasm, the relationship between anxiety about sex and poor exposure to positive self-awareness about one's own sexuality. therapists will assist with reconnecting sufferers with a more positive view of sex and one's own sexuality. In this instance, masturbation is encouraged to learn about what feels good and what is desirable without needing to attend to a partner's needs. The gentio-pelvic pain penetration disorder, the vaginismus, is not a physical defect. Rather, it's a psychological state that affects comfortable intercourse. Treatment is usually involving cognitive and behavioral techniques, including relaxation techniques and the use of dilators to improve sexual experiences. Now, this has been a really quick overview, but I hope you take the time to read some of the breakout boxes and review the content for this chapter. It might help give some light into some of the issues you see in news feeds, particularly around gender dysphoria, and seeing more examples of people who are choosing to transition from one gender to another. I hope this has been helpful. Good luck and carry on the good work, everybody. We're drawing near the end. Bye now.